Umair Rashid. I'm a colorectal and pelvic floor surgeon. I'm currently working in Liverpool, UK. I'll share my screen for the presentation. Can you see my screen?
Yes, we can.
Okay. The topic is functional pelvic floor disorders. It's a huge topic. Unfortunately, it's difficult to cover it in 20 minutes, and I can talk hours and hours about it. So I've decided to choose some topics and then discuss about them. It's an unknown territory. It's not very common, pelvic floor surgery, especially colorectal. There are rare conditions, not rare conditions, common conditions, but rarely addressed, especially once they are attached with some social and cultural stigma with it. So what are pelvic floor disorders or functional bowel disorders? So we talk about chronic constipation, obstructive defecation syndrome, fecal incontinence, rectal prolapse. LARS, I'll probably not discuss about LARS in this talk. I'll try to pitch it to the general surgeons so that everyone can have an understanding. And then there are no disclosures and no conflict of interest. There's no industry products I'll be discussing in my talk. So we start with chronic constipation. Probably surgeons, you'll be thinking about what surgeons have to do with it. But yes, you sometimes have to do with functional bowel diseases, and you need to know about them. So the criteria, less than 3 spontaneous bowel motions per week for at least 3 months, and at least 1/4 of these movements are characterized by one of these following things. So then you'll call it chronic constipation. Also, I'll leave these slides with Professor Tullet. If anyone needs them, they can have them later on. So what's the pathophysiology of this chronic constipation? I think that you can divide it into 2 categories. Either the colon is not mobile enough, or the motility, there is some problem with it. So there is some delayed movement in the intraluminal contents, or you're not able to expel it. And there can be structural disorders and there can be functional disorders responsible for it. Diagnostic investigation. So when you come see a patient in your clinic, you obviously take a very detailed history, and then you have to think about what investigations you're going to do. So we said that there could be problems with the motility of the colon, and there could be problems with the evacuation. So if you're concerned about the motility, you'll do gut transit study. And there are a number of ways you can do it. You can do it by X-ray with radiopaque markers. You can also do scintigraphy. You can do wireless capsule motility investigations. The simplest thing I would suggest is that you do a gut transit study with radiopaque markers. Give them 5 to 10 radiopaque markers, do an X-ray after 5 days or 120 hours. And if there are more than 20% retention, for example, if you give them 10 and the 2 are still in there, then you can consider it a slow transit constipation. The test for evacuation problems, you can do balloon expulsion test. That can be done in the clinic. You have to give a 50 ml balloon. It's inserted in the rectum, and the patient is asked to expel it. And if they can't expel it within 3 minutes, that's a positive test. Defecation proctogram, again for evacuatory functions, dysfunction, it's probably the most important test. The way to perform it is that barium is mixed with a porridge paste and instilled into the rectum. The patient's asked to pass that whilst you're taking an X-ray. It studies the dynamics of the pelvic floor, how the coordination of the pelvic floor is, if there are any structural disorders that you can see. Finally, you can do anorectal manometry for these patients in the push maneuver, which assess the recto-anal inhibitory reflex. It's uncommon in adults, but in a children population, especially with Hirschsprung, that's a good test. For rectal sensation, because some of the evacuatory dysfunctions would be because the rectum sensation is poor. So the reservoir is keeping all the stool in it, but it does not get the sensation. So you may have the threshold pressures. The way you do it is it's a special probe that you use, and you fill the rectum with some water. So usually the first sensation to have the urge for defecation, and then you note the sensation when they have to defecate. And then finally, the maximum tolerable pressure. Management. So probably the first thing you're going to suggest to your patients is non-medical management. And I think for medical students or anyone practicing surgery or medicine should know about the non-medical management. Fiber supplement. It's important that you told them that it's the soluble fiber that they're going to give them any benefit, which is psyllium or isbagol, commonly known in Pakistan. 25 to 30 grams should be given every day. The problem is don't give them in slow transit constipation because it will worsen it. So that's, I think, why your first screening test or the first test you should do in these patients with chronic constipation is to make sure it's not slow transit. With the fibers, you can give them prebiotics, inulin-like factors. I think the foods I would suggest is bananas and garlics. They're quite useful. And they actually increase the gut motility. So if they've got slow transit constipation, possibly prebiotics will be helpful in that sense. When we're giving them prebiotics or fiber supplements, water intake is important. So make sure that they're taking at least 2 liters of water a day. Drinking too much water is also counterintuitive. So for the fibers to work and make the bulk in the bowel, about 2 liters of water is enough. Physical activity is important, especially in elderly population, because part of their chronic dysmotility or slow transit is reduced physical activity. So about 30 minutes a day for 3 days a week in elderly population. It doesn't really make a difference in younger people. Bowel habit retraining, so give them the advice that it's surprising that not many people are potty trained when they are children, and that can have detrimental effect as they grow up with their bowel habits. So telling them how to train their bowels to open it properly, it's usually you suggest them that try and go to the toilet only when you have the urge to go to the toilet, and try and cycle your bowel motions around your eating habit. So usually the colonic, if you understand the gastrocolic reflex, happens right after you've eaten something, and that's probably the right time to have a bowel motion. And then finally, transanal irrigation. I've seen non-medical management. It is kind of medical management. They have to empty their bowel, or usually with evacuatory dysfunction, if the rectum is full and it's not been able to empty itself, then irrigation can be used. We'll talk a little bit more about it later on. What are the medical management? I think that's another important thing that people should know about what laxatives to give and when to give, and how do you do the step-up treatment. So I think the first line of treatment will be osmotic laxatives, which is Macrogol or PEG. They are for if the patient is passing frequent hard stool, or they have IBS, which is irritable bowel syndrome associated with constipation. So they're constipated and they have abdominal pain with it. But be mindful that they can cause bloating. So again, slow transit constipation, avoid them. So I'll go back to my first line of the talk again, that in terms of constipation, do transit studies, they'll give you valuable information. Stimulant laxatives, which are quite commonly used, like Senna, I'm sure everyone would be aware of that. They shouldn't be the first line treatment, and again, not for a long-term use. They can cause melanosis coli in the long-term use. But yes, use them if there is any failure of osmotic laxatives, or patient has got slow transit constipation, then that will become your first line treatment because they have stimulating effect on the bowel. Stool softeners are brilliant in combination with either of the above, especially in elderly population. They are good in slow transit and elderly patients. A step-up treatment would be then prokinetics, which is procalipride. They're brilliant in slow transit constipation if the first-line treatment has failed. And then finally, pro-secretory agents like linaclotide. useful in abdominal pain as well. So really helpful in IBS type C. I think what I've written in red is that you have to give about 4 to 8 weeks of treatment before declaring failure. And the other thing is important to tell the patients that these treatments are generally lifelong treatments. Surgical management, I think they rarely need surgery, but they sometimes do if they're resistant to the medical management. Loop ileostomy is a safer option to start with because it's reversible. You'll give the time to the patient. If they've got upper GI or small bowel troubles, a lot of flatulence and bloating like symptoms, they may not do very well, and then you can reverse it. But if they do very well, then you probably can keep it for lifelong, or think about doing a colectomy and ileorectal anastomosis, which is the next thing. Before you consider colectomy or ileorectal anastomosis, make sure there is no evacuatory dysfunction. So again, rule out slow transit study, differentiate between whether it's a slow transit constipation or an evacuation dysfunction. Slow transit constipation, they'll benefit from a colectomy and ileorectal anastomosis. Evacuatory dysfunction, you'll probably ruin their life if you do that. Sacral neuromodulation, we'll talk a little bit about it in fecal incontinence, but it has its role in evacuatory dysfunction. Antegrade continence enema, so you make a hole in the appendix, take it out to the skin, and the patient can then cannulate it and run enema through it or saline through it to cleanse their bowel. Works in the more pediatric population and the younger age group. It's not a brilliant thing. I think we do less and less of these now. Wow. And then sigmoid colostomy if they've got evacuatory dysfunction, but they've got a normal colon, and then the stoma will benefit them. The next thing we'll talk about is just obstructive defecation syndrome. So the cardinal symptoms that the patient will have is they are straining at the stool, they have a sense of incomplete evacuation, and they are digitating. So they have these 3 symptoms, then you call them, they have obstructive defecation syndrome. That's part of the constipation, but they just can't empty it. The colon is working fine otherwise. The investigation that you do for your history and examination, defecation proctogram is brilliant. You can do an MRI or MR proctogram. The downside is the patient's actually lying down, so it does not give them the full picture. So we tend to use defecation proctogram for ODS. The ultrasound scan, which can be done as screening tool in the clinics, transperineal, vaginal and anal ultrasound scan, gives you information about pelvic descent, rectal intussusception, and rectal prolapse as well. That's usually visible. And then you would like to do rectal manometry and pudendal nerve latency. So sometimes the problem is actually the pudendal nerve hypersensitivity that happens over the period of time in elderly population and can be associated with constipation or fecal incontinence. It can also happen in a patient who have undergone a prolonged second stage of labor. So quite common, well, not quite common, more common in females. So what are the associated conditions? So obstructive defecation syndrome is a syndrome. There are a number of conditions which will present with this. So pelvic floor dyssynergia or anismus, you can see it on the defecation proctogram. Essentially, when you're passing, the defecation reflex, your puborectalis muscle, which is maintaining the rectoanal angle, it relaxes as the rectum contracts. In dyssynergia, it fails to relax, so it does not correct the rectoanal angle for the stool to pass easily. And the treatment for that would be, you can see it on the defecation proctogram, the treatment would be either electrostimulation or a Botox injection in the pelvic puborectalis muscle. Pudendal neuropathy, we said that in elderly population or prolonged second stage of labor can happen. Again, electrostimulation can be used for that, or biofeedback will help these patients. Rectocele is bulging of the rectum into the rectovaginal septum. The classic history the patient will give you is that once they can't open the bowel with the struggle and the straining, they would push in the perineum, or some people would push in the vaginal opening to help it empty, because that's where it's bulging into it. Again, diagnosed on defecation proctogram. Treatment, generally, they're amenable for transvaginal repair and sometimes transanal repair. You don't necessarily repair them unless they are large enough or causing symptoms. And enterocele is a small ball pushing into the rectovaginal septum and causing trouble whilst you're opening the bowel or rectum is trying to evacuate. They're again a bit tricky to manage. You can diagnose them in defecation proctogram, but you have to give oral contrast to the patient, or you can diagnose them easier on MR proctogram and you can see the small bowel as well. But bear in mind, defecation proctogram is just an X-ray with contrast in the rectum. The management is you have to reduce that cul-de-sac, deep cul-de-sac where it's going into, so ventral rectumectopexy is useful. And then rectal interception, I think it can be easily diagnosed on the transperineal scan that you can do in your clinic. And the management depends on whether you can do a stapled transanal repair like a STAR procedure, but it's got some complications associated with it. And the other option is doing a ventral mesh rectopexy. We'll talk a little bit about fecal incontinence. Again, it's quite common, but a lot of stigma associated with it, usually in elderly population and female after multiple childbirths. The criteria will be recurrent episodes. There has to be about 3 months. So you take a detailed history, you have to take obstetric history, you have to ask about any problems in the delivery, any tears or repairs during vaginal delivery, prolonged second stage of labor, ask about histories of multifunction problems like urinary incontinence, any multi-compartment and prolapse like vaginal or uterine prolapse. Ask them to give a stool diary for about 3 weeks' time so you can then give them a realistic expectation of improvement in their symptoms with any treatment that you're going to offer. Unfortunately, no treatment is going to give them 100% recovery back to the normal function. There are a number of different incontinence scores you use. You can use, I use St. Mark's incontinence score in my practice. Give them Bristol stool chart to see what consistency of stool they are passing, because one of the things you can do is if they're passing too liquid stool, the first thing you can improve that by bulking it up a bit. You can use some fecal incontinence quality of life. It is a quality of life problem, so it's really important that we get that and we address that and treat it as a quality of life issue rather than a curative disease otherwise. Rectal examination is important. You assess when you do the rectal examination, feel for the resting anal tone and ask the patient to squeeze and assess what the squeeze pressure is like and see if you can feel any mucosal abnormality. You can start, I would suggest that start the first line management before doing any test, like your good history, thorough examination. Once you made the diagnosis, the patient has got fecal incontinence, start them on dietary modifications, again, making sure the stool is bulky enough so that they don't get accidents. Give them antidiarrheals like loperamide, I think it's called Imodium, and codeine. They both work brilliantly. Loperamide, the patient can tailor themselves the dose. They can safely get about 16 to 32 milligrams a day. If they're getting fecal incontinence, they are bound to get skin problems in the perineal skin. So make sure you give them some advice or prescription for barrier creams and absorbent pads. Pelvic floor physiotherapy, you can refer them to YouTube to watch some pelvic floor physiotherapy or pelvic floor exercises, or print something in your practice and give it to them so that they can use it. Half of the patients will show some improvement with pelvic floor exercises. Give them 6 months time for that. And again, biofeedback, bowel habit retraining, and just to make sure how they're opening their bowels in the normal way that they should. Do some investigations for them. So colonoscopy and pelvic ultrasound scan is to rule out any other pathology which is responsible for it, like anything like a rectal cancer or a big rectal polyp. Probably the most important investigations are anorectal physiology studies to check for the function. We talked about it a little bit earlier on, that you check the rectal sensations, you check the rectal pressures. High resolution anorectal manometry is the next thing, which checks the sphincters. their functions, their squeeze pressure, high pressure zone in the rectum. And finally, an endorenal ultrasound scan to assess for any defects in the sphincters, which could be probably because of obstetric injury. Your management, I think, the non-surgical management are tibial nerve stimulation. We're trying to stimulate the sacral plexus by stimulating the tibial nerve around ankle. I don't think it's probably you'll come across it in Pakistan. You might do. I'm not aware of that. And then anal plug, it sounds horrible, but it's brilliant for people who've got spinal disorders and very elderly population where they can't open their bowels and they're struggling with it. Anal plug will actually keep it under control, and they'll remove it once at some point during the day to evacuate their bowels. The surgical management is sacral nerve stimulator, and I'm not sure whether it's available in Pakistan or not. It's a quite expensive kit to use, but it's possibly got the highest rate of control or cure of the disease in that sense. Injectable bulking agents to inject into the intrasphincteric space to just make the bulk a bit bigger. Magnetic anal sphincter has been used with the conflicting evidence. It's the same as you use in the gastroesophageal reflex. And then finally, it's a colostomy if nothing is working. I think probably the last thing I'm going to discuss is rectal prolapse. It can present with constipation and incontinence, and that's something that you probably do see in your practice as general surgeons or colorectal surgeons. The important tips in terms of examination: if you can't see the prolapse in your clinic, you ask the patient to strain whilst they are on the toilet so that you can see. You can keep the toilet seats in the clinic for that. Do a digital rectal examination to assess the height or the takeoff. So what that means is where the prolapse is coming from on the inside, because if it's more than 5 centimeter high takeoff, your approach will be different to the low takeoff. And do a proctoscopic examination to look for any rectal ulcers. To differentiate between a full thickness rectal prolapse and a mucosal prolapse, and the rectal prolapse will have concentric rings in circles, and the hemorrhoids or the mucosal prolapse will have radial invaginations. And what investigations will you do? You do endoscopy in all cases. The polyps or cancer can be the lead point, so you need to rule that out. Transperineal scan, I do that in my practice for...
Umair, can you please wrap it up? We are short of time right now.
Yeah, I think it's probably the last slide anyway after that. You do this physiology study and again, defecation proctogram. If it's quite evident, you don't have to do that. Your management goals are eliminate the prolapse, which is the anatomical disturbance. You correct the functional abnormality by pulling up the rectum, and avoid creation of bowel dysfunction. The obstructive defecation patients can get worse if you do a VMR for a prolapse in them. So the choice of operation, that probably is the most important thing that you need to know. If the patient can't tolerate general anesthesia, then you could do DLOMs or Altmairs, which are perineal procedures under spinal. If they can tolerate general anesthesia, then again, go for the takeoff. If it's low takeoff, you can still offer them a perineal approach, like DLOMs, or ideally still abdominal approach, which has got more results, better results in terms of recurrence than any perineal approach. If it's high takeoff, then obviously abdominal approach is better. If they've got a massive prolapse, they probably have a redundant sigmoid colon, then either an abdominal approach with resection, like a resection rectopexy, or Altmairs if they're not fit for general anesthesia. That's just my details. If you have any queries or any case discussions in future that you want to do, you can get in touch with me.
We'll be taking your questions at the end of the session and panel discussion.
Sure.
Thank you.
Thanks.